Welcome back to Family Planning and Abortion for Medical Students. Today, we will be discussing methods of pregnancy termination as well as the public health impact of the legal status of abortion. This is the last video in the series covering APCO topics 33 and 34, Family Planning and Abortion. We will be covering the highlighted APCO learning objectives regarding methods of termination and potential complications of these procedures, as well as the public health impact of the legal status of abortion. Our learning objectives for this video include understanding the two major types of abortion procedures, including how and when they are performed, understanding the possible complications of abortion, understanding why a patient may choose one option over another, practicing our knowledge with a case, and understanding the impact of Roe v. Wade and the challenges surrounding the legality of abortion. Let's start with discussing some definitions. We will be discussing induced abortion, defined as the medical or surgical termination of a pregnancy before the time of fetal viability. This is in comparison to miscarriage, also called spontaneous abortion, which is a pregnancy loss prior to 20 weeks gestation, which we will not be discussing. Induced abortion has been legal in the U.S. since the Supreme Court's decision in 1973 on the case of Roe v. Wade. Since that time, various state and federal laws have made attempts to limit access to abortion services through trap laws, waiting periods, insurance restrictions, and more. We'll talk about this more at the end. A few notes on the timeline and general principles regarding abortion procedures. Whether or not a procedure can be performed depends on the gestation of the pregnancy. This image from Healthline is helpful in seeing which options are available for abortion at each week of pregnancy. Generally speaking, as the length of the patient's pregnancy increases, there are less options for procedures. I will not be discussing all of the options in the graphic, but it's a good reference for what's available depending on gestational age. Another important thing to note is the use of ROGAM in abortion. As I'm sure you learned in your reproductive or hematology courses, pregnant people should be assessed for their Rh status, and Rh-negative patients should be given ROGAM prior to delivery. The same is true for patients choosing a medical or surgical abortion. Another note is that for both types of surgical procedures, antibiotics are given afterwards to prevent infection. This is sometimes done with medical abortion as well, but less commonly as infection risk is very low. So as stated, the two types of abortions are medical and surgical. We'll start by talking about both options in the first trimester. Let's start with the medical option. With this method, patients take a drug or a combination of drugs to induce abortion. The three primary medications that have been researched and widely used are mifepristone, methotrexate, and misoprostol. Mifepristone is an antiprogestin, meaning that it blocks progesterone's action in the uterus, causing atrophy in the decidua. The lack of nutrition from the decidua causes the blastocyst to die and detach from the uterus. Methotrexate is a folate antagonist. As I'm sure many of you learned during your reproductive unit, folic acid is crucial in fetal development. Methotrexate's competitive inhibition of folate binding stops the growth of the fetus. Misoprostol is a prostaglandin analog that binds to myometrial cells, stimulating uterine contractions to aid in expelling fetal tissue. Although all of these drugs have been heavily studied, the typical regimen in the U.S. is a combination of mifepristone and misoprostol. This regimen is indicated for pregnancies up to 10 to 11 weeks of gestation and is not prescribed to patients beyond this gestation. Medication abortion is allowed in the second trimester, but it must be performed in a clinic, so I'll only mention it briefly when I discuss second trimester options. Surgical abortion in the first trimester includes aspiration. This can be performed between 6 to 16 weeks gestation. This is when a dilator is placed in the cervix to create a larger opening and local anesthetic is injected. Once the cervix is dilated, a cannula is inserted into the cervix and suction is applied either manually or hooked up to a vacuum device to remove the products of conception. The procedure is brief, usually around 10 to 15 minutes. Patients can expect to experience cramping during and for a few days after the procedure, as well as a few weeks of irregular bleeding. Patients should take antibiotics and pain relievers as needed afterwards. Now let's talk about second trimester options. Medication abortions in this trimester are not as common as surgical procedures, but are still available to patients. They involve a similar regimen of misoprostol and mifepristone, but at a higher dose. These pills cannot be taken at home, and the patient must be in clinic for this type of abortion. During the second trimester, after 13 weeks gestation, dilation and evacuation is performed. This is when the cervix is dilated and the products of conception are removed with forceps. Usually, the cervical dilation will be started the day before the procedure with an osmotic dilator to ensure that the opening is large enough to perform the procedure. The dilator is called a laminaria. It is a small tube made of seaweed that opens the cervix over the course of several hours. Patients will generally have this dilator placed 12 to 24 hours before their procedure and leave it in the cervix until the time of their abortion. Before the procedure, a patient may get general anesthesia, spinal anesthesia, or a block and a sedative depending on the clinic's practices and patient preference. A cannula and forceps are placed into the uterus and the products of conception are removed. A curved instrument called a curette is then used to scrape the lining of the uterus to ensure all fetal and placental tissues are removed. The tissue is then examined to ensure that all of it has been removed. This can also be confirmed via ultrasound. Like a first trimester procedure, cramping and bleeding should be expected afterwards, and over-the-counter pain relievers as well as prescribed antibiotics should be used. To summarize, in the first trimester, patients can undergo a medical abortion through a mifepristone and misoprostol regimen or a surgical abortion through aspiration. In the second trimester, patients more often undergo surgical abortion through dilation and evacuation, but also have the option of medication abortion in the clinic setting. A last note, although these procedures are legal for both trimesters across the U.S., legality of abortion is determined by fetal viability, which differs in each state. In some states, you will find no providers that perform abortions over 20 weeks, and in others that will provide abortions well into the third trimester, although this is rare. We'll talk more about access a little later. Let's talk now about why a patient would choose one method over another. In both cases, patients can have medical histories or comorbidities that make them better candidates for medication or surgery. Besides that, patients elect for medication abortions for a number of reasons, including not having to be in a doctor's office during the procedure, and choosing a location they feel more comfortable in, deciding who gets to be around during the procedure, and having a more natural feeling because it's more like a miscarriage and not as invasive as no surgical tools are used. Because second trimester medication abortions are often wanted pregnancies and result from fetal anomalies, medication abortion in the second trimester can allow the patient to experience labor and hold and see an intact fetus, although this must be done in a medical facility. Patients may elect for surgical abortions for a number of reasons, including wanting to be around healthcare professionals and supportive staff members, as well as the relative speed of the procedure. Patients can walk into the clinic, undergo a 5 to 10 minute procedure, and no longer be pregnant, compared to up to 24 hours for medication abortions in the first trimester. Similarly, in the second trimester, surgical abortion is the preferred option and is much shorter and slightly safer than medical abortion at the same gestational age. Now let's talk about the complications for these procedures. The most common complications for both types of abortion include uterine perforation, cervical laceration, hemorrhage, incomplete uterine evacuation, and infection. Infection is generally related to an incomplete abortion, which is when some of the products of conception remain in the uterus after the procedure. Overall, the rate of major complication is below 0.31% and below 5% for minor complications, and the overall mortality associated with abortions is 0.6 patients per 100,000. So now let's practice with a case. Emma is a 22-year-old G1P0 with no significant past medical history presenting to your clinic with a confirmed positive pregnancy test at 8 weeks gestation that is considering an abortion. What are her options? You can pause now to think about it or go back and review the previous slides. So Emma is in her first trimester of pregnancy. She can have a medication abortion that can be done at home or another place she feels comfortable, or an aspiration procedure in an outpatient clinic. After fully discussing her options for continuing her pregnancy and for abortion procedures, Emma states that she wants an abortion and wants the procedure to be over as quickly as possible. She is also nervous about complications. What would you tell her? Feel free to pause. We can tell Emma that surgical abortions are usually a quicker procedure and can be done in less than a half an hour, whereas medical abortions are slower and can take up to 24 hours. We can tell her that the most common complication she would experience and reassure her that whichever procedure she chooses is safe and has low rates of major complications and mortality. As a side note, if you're interested in a patient-friendly resource to help your patients in learning more about and deciding between a surgical and medical abortion, I've shared 2 resources from Planned Parenthood in the folder for this video. I hope that exercise was helpful. Switching gears a bit, for the next part of the video, I'm going to be discussing the public health impact of the legal status of abortion using a report from the Guttmacher Institute compiled in 2003, 30 years after Roe v. Wade was decided. I'm hoping this discussion will help in understanding the nuances and challenges still faced by those seeking and providing abortions. Since the Supreme Court decision of Roe v. Wade, the public health and political landscape regarding abortion has changed dramatically. This ruling was especially beneficial for unmarried people and racial minorities, as these were groups that historically had not always had access to safe and reliable abortions. The new legal status of abortion improved access for many patients, allowing more patients to have abortions in their home state and at an earlier gestation, with more than half occurring before 8 weeks gestation. Prior to this ruling, many people had to travel far to get abortions and often were not able to obtain them early in pregnancy due to having to travel and other restrictions. This ruling also led to more abortions being performed at outpatient clinics instead of in hospitals, which paved the way for many other specialties to start performing routine outpatient procedures. Roe v. Wade also prompted a lot of funding for research and training in abortions. This not only improved the skill of doctors performing the procedures, but led to new safety discoveries, such as learning that vacuum aspiration was better than dilation and evacuation in the first trimester, and increased the safety of dilation and evacuation in the second trimester to become more popular than the medical abortion in this trimester. Overall, this research and training led to more safe and legal abortions, as well as a decreased maternal mortality rate. This quote from the Guttmacher article says it best: "Roe v. Wade transformed abortion from an unsafe, clandestine procedure to one performed under safe medical conditions." Although at the time of this recording, Roe v. Wade is still in place, that is subject to change depending on our Supreme Court. Even as Roe v. Wade stands, while individual states cannot ban abortion outright, they can and have enacted laws that put immense strain on those seeking abortion and on abortion providers themselves. Some of these include things like unnecessary strains on abortion providers and their facilities that have caused some to be shut down or providers to not be able to practice, leading patients to having to travel far for procedures. Some states have stipulations making it difficult to obtain government or public funding and even insurance coverage for abortion procedures. And then a slew of unnecessary logistical technicalities, such as requiring one or more parents to agree to a minor's procedure, a waiting period that can be a huge strain on patients traveling far or taking off from work to get the procedure done by forcing multiple appointments, and even mandated counseling that can involve medically inaccurate information, such as that abortion is linked to future breast cancer or infertility, neither of which are true. Unfortunately, some states have also written in their laws that if Roe v. Wade were to be overturned, abortion would automatically become illegal in that state. Others have gestational limits at 6 weeks, such as heartbeat laws that are pending. Other states try to enact dangerous laws in the field of reproductive health, including laws that have absolutely no basis in medicine, a prime example being Ohio's attempt in trying to order physicians to reimplant ectopic pregnancies or face what has been termed as abortion murder charges that could be punishable by death. So that is not great. With all that being said, it's difficult to know the future of abortion procedures in America, as this issue and access have been controversial and highly personal to people all over the world for decades. Sorry to end this video on such a bleak note, but thank you for listening. While the future of abortion access is cloudy, it is imperative that students and residents continue to be trained in and able to perform these necessary medical procedures. I hope you all have built some of the foundational knowledge that will help you excel on your OBGYN rotations and become more compassionate and competent physicians.